Can you see my screen?
Yes.
Okay.
Yes.
And I'm loud enough?
Correct.
Okay. So good morning, everybody. As usual, we might have a problem with getting a room. So Faith told me yesterday that we just do it online. I saw the struggle you had on Monday. Dr. Gitinji could not get a room, and so this year will be sockets and etc. But it's a struggle. But let's just use this model because it still works for us, and we'll explain everything. So this morning we are in the liver now. We are in hepatobiliary. So today we look at the liver. Hepatitis B and C infection or alcohol, which is liver cirrhosis. So we look at liver cirrhosis at the beginning, and then after liver cirrhosis, in our schedule today, we'll then look at a complication of liver cirrhosis, which is hepatocellular carcinoma. We look at other tumors, but major a lot on hepatocellular carcinoma from the hepatocytes. So it's a primary malignancy of the liver. So that's how we're going to do. Let's look at our learning objective. Review the physiology, the normal things. Just review, recall. It's a recall. So I'll just show you one slide of the recall of what you already did in your anatomy, and define it and look at the characteristics that are involved in liver cirrhosis. We will look at its etiology, what really causes those characteristics that we are seeing. Then look at, now that the liver is cirrhotic, how does it appear? Morphology, both grossly and microscopically. After that, we will look at how the patient presents and then the complications. Okay, one of the complications also, remember, this is portal hypertension, not systemic arterial hypertension. Okay, then we'll describe the liver tumors briefly. So it's a long class, but I know we'll manage because most of it is just pictures of describing what we see. So we start with liver cirrhosis. Okay, first we review the anatomy of the liver, as I said. So this is just a liver lobule, like how it looks. This is a skip diagram to show how it looks. So our liver usually looks when we look at it histologically. I'll show you the histology part. This is a diagram to make it easier for you to understand. I hope you're able to see. Okay, you're able to see where I am at. So, and you can hear me. I'm not muted. Okay. So here we have your central vein or the hepatic venule. Okay, the hepatic vein. Okay, right in the middle. I hope you can see my cursor here, and then you can see there are these tracts. These are the triads. I mean the tracts. Sorry, which are coming to here where we have our portal tract. So the tract has your portal vein here. It has your hepatic artery. Then it has your bile duct. Okay, at this corner. So it's a hexagon. It's a hexagon. You can see the number of corners it has. So it appears like that. So here at the portal tract, you can now describe different zones as you see. So if you're just close to the portal tract, you'll say periportal, just near peri. Okay, then you can be in the mid zone or you can be central lobular. This is the central lobule. Okay, the vein. So moving this way. You can also describe it as an acinas, okay, like I've drawn on this side, where you draw sort of like a triangle, like this triangle, like this here on this side. So you'll be seeing the tracts inside this triangle. And now they'll be coming where the tract is, where the portal tract, where you have your bile duct, you have your hepatic artery and you have your hepatic. So you're having them like this on this side. So you can also describe it as an acinar like that. And here you talk about how close it is from the portal tracts, and these penetrating vessels. You can see these ones are like how close they are to the penetration of the blood vessel. Okay, so you describe like that towards the central vein. So this is a typical way how the liver histologically usually look from the central vein, the way portal vein, the portal tracts, all the way to the central vein like this. This is the normal way. So in our learning today, we will discover that when we talk about liver cirrhosis, which is fibrosis, now you have all these night tracts disoriented. This architecture is lost. So instead, you'll have fibrosis and round nodules here everywhere on this. So this normal, nice blood acina or lobule is lost. And you can see this lobule is oriented this way in this architecture because of the portal tracts and the central venue. So there's a way the blood is feeding into this. There's a way that the bile duct is. If you have a scar, because fibrosis is healing with a scar, with nodules like this whole architecture is lost. So then the blood supply to those hepatocytes is lost, is disoriented. So that's why you have to remember your normal anatomy. Normal anatomy. And this is what I was describing. Okay. So this, if you look clearly, you see these tracts I'm talking about, the portal tracts. You know, these lines like are going like this. On histology, this is what we see. This is what you see. You see the tracts like this lines of dots going like that. So this is a portal tract. Okay. So you'll have your portal bile duct. Okay. This is what I'm saying. The central vein is right here. Okay. This one is here. Or portal vein and your portal, the artery, the duct, and the vein. Okay. So this is what you see on histology. Okay. We have to orient it like this so that we're able to describe the pathology. Okay. So this is normal histology. Okay. So we go now to how it will look normal histology again. Nice picture here where I've labeled. This is your portal triad. Okay. Okay. Periphery of the lobules. Remember, we call this a lobule. This is a central vein. So you have your three things area. Here, there is no fibrosis at all. So you can see the tracts going like this. Okay, moving nicely. This is a central vein around here. So the hepatocytes are like in cords, you know, rows. Okay, which are radiating around them. Central vein towards the triads like that. Same picture here you see nicely on this HNE. Okay, that's just histology. Okay, so we go into now our pathology, the abnormal. So, what is cirrhosis? What is cirrhosis? Cirrhosis is derived from the Greek, which says kirosis, which means tiny, tiny. That's the orange color or orange yellow color that when you have a liver that orange yellow color. So this one was it was known before, but the name cirrhosis was given by this guy who discovered the stethoscope, the stethoscope that we use 1999. So that's when he discovered this, gave it an entity of cirrhosis. But what does it? What is the actual definition? Here is the actual definition. Okay, so liver cirrhosis is a consequence of a deceased liver because of repeated placement of the normal scar tissue and regenerating nodules. Okay, and because of that, the function of the liver is drain, like the one you see in the butchery. Compare it with a cirrhotic liver. So there's fibrosis with healing of scars and several nodules that you see. They're called regenerating nodules that you see here. So that's how nodules regenerate. Because the normal architecture is taken away. So the things you know in normal functions of the liver will not happen. Please don't Google. Just put them. And today we are many. I don't know where the other people are coming from. You know, when you come physical, we are 20 or 15. Now we are 39. Okay. I pause there and ask, what are the functions of the liver? Functions of the liver. 1 minute only. Start, you can, and don't Google. That is makes the class boring. Okay, let me see. Detoxification, metabolism. Okay, but you have to define metabolism of what? Detoxification, thermoregulation, okay, albumin synthesis, deamination, bile production. It's not production, it's conjugation. Where people, the way you're writing this thing, so you've done clinical chemistry, and it's a big topic about liver function and how we analyze. The way you're presenting here, I thought you just did. Are you doing clinical chemistry right now? Faith, or anybody, Julius, have you done clinical chemistry?
Yes, we did 3.1.
Yes, but that is a big topic in clinical chemistry about liver function. I'm not even going back to your physiology and biochemistry. I'm just asking clinical chemistry. It's a whole topic you have to know how to do about the liver function and how you do the biochemical test for liver function. So for you to do liver function abnormality or what you analyze in the lab, you must be knowing what are the actual functions. Because you've only written 2 or 3, and it's a whole list. You guys need to go back and look at your work. So there's, of course, there's detoxification when it's conjugating bilirubin. There's steroid hormone, the synthesis that goes on, the storage of vitamins. There's synthesis of proteins. You know, all of them except the your lymphocytes, etc. I mean, there's a list. So you need to go check from your notes for chemistry, chemical pathology. Okay. So those are the things I'm saying. When the liver becomes cirrhotic, then it can't do those functions. There's a role of coagulation, it can't do it. Remember, it synthesizes coagulation factors also. Okay, you have fibrinogen, etc. It's not able to do that. Okay, yeah, so very important. And by the way, go review because those are questions we ask, we expect you to be knowing. Okay, so what's the etiology? What are the things that can actually lead to this cirrhotic liver? Of course, those are the main ones that we all know. Okay, alcohol. So you can have an alcoholic liver disease. You can have viral hepatitis, and this one for the viral hepatitis, you already did it. Mostly the B and C, because they're the ones which go into a chronic phase. Your A and E hardly get into a chronic phase, and they're fecal oral. Your D usually rides on the B and C. Yeah? So many times your B and C are the ones that you get acute hepatitis, then you move to a chronic hepatitis, and then the chronic may lead to liver cirrhosis. You can have your hematochromatosis where you have overload of iron. You may have biliary disease. I think that's the next topic after this. The different types of biliary diseases, primary sclerosing cholangitis, there are many which can also lead to liver cirrhosis. Then you have autoimmune hepatitis that you discovered on Monday. That was you covered. And then we can have a non-alcoholic steatohepatitis. Okay, there are different names of calling it. Just saying non-alcoholic. When you have stasis. And then you have a fatty liver disease or there's a 10% where we really don't know the cause. We call it cryptogenic. Okay, there's a 10% that you don't know that you have that. So, and the list can be longer than this. You'll check in your Robins and add more. Okay, for the cause, for the etiology. Okay, so what about the pathophysiology or the pathogenesis? How does this, say, viral hepatitis or alcohol abuse cause cirrhosis? Before I even move there, I just want to mention when we were in 3.1, we did general pathology. And the first topic we did was cell injury. So we injured a cell, okay? And then after we injured the cell, we did inflammation, okay? So a virus has injured the cell, say hepatitis had injured the hepatocyte. Then there was a reaction of the body towards the injury to the hepatocyte, which was inflammation. So it brought chemical mediators, many of those came in, your white blood cells to fight that inflammation, okay? To fight that cell injury through inflammation. After inflammation, we went through healing. That the consequence of us fighting this infection, hepatitis, the body can, one, is able to, remove that infection completely and you heal with complete resolution, or it could remove it and there's some sort of healing with regeneration, okay? And there's sort of some healing with fibrosis, So there's a fibrotic part in it. So that's the same story we are going to discuss today in liver cirrhosis. Injuring the hepatocyte, inflammation of that hepatocyte as a reaction to the injury, and then healing with fibrosis, which is what liver cirrhosis is. And that's what I'm showing on this diagram. Okay. So the primary event, which is injury to the hepatocyte, then how does the body react to the injury? You bring in your inflammatory process, okay? So it will initiate an inflammatory response. Your white blood cells will come there. Your cytokines are released, just to fight this injury, okay? Then, of course, with the fight, there'll be some destruction of the hepatocytes as you're doing it, the bile duct cells, vascular endothelium, it's now a fight. So some things like those will with proliferation of some of the cells. There'll be healing. And there's also the formation of a fibrotic or a scar, okay, during that process. So that's basically the pathogenesis of cirrhosis, okay? Now, this is the main picture. So in the next 4 slides, I break down each of these, okay? Are we together till there?
Yes.
Okay, good. So we are looking at this in a little more of details, okay? Let me bring cell, what happens, okay? And it's chronic, like, as I said, for example, if you say it's alcohol, it is not alcohol time, okay? So repeated and persistent damage from alcohol or that virus or autoimmune or those toxins will cause hepatocyte death, process that we are healing, or it could be necrosis, okay? So there's hepatic death, signals, to fight this alcohol or injury, a cycle of injury and repair. Things, because they're chronic things, are going to heal and repair. Okay, there's a cycle like that. So what happens when you're saying the inflammatory thing? So the inflammatory cells, when they come in, they're trying to fight. They'll produce cytokines. The liver macrophages are going to produce your interleukin-1, etc. Then some of these things released by the macrophages are going to activate your stellate cells. Remember, in the liver, there's a support. There's a hepatocyte, then there's a connective tissue support. one of the connective tissue support is your stellate cells. Okay, so the stellate cells are the ones that are going to be activated now, and they will produce. They'll they'll change and become myofibroblasts, and myofibroblasts will lay down collagen and extracellular matrix, forming fibrosis. Okay, myofibroblasts. Okay, which is what I'm saying here. So the myofibroblasts will lay down excess collagen and extracellular matrix, and they lay it down there. Of note is in the normal liver, what you already did in histology, we usually have different types of collagen. So your type 1 and type 3 collagen are usually in the interstitial space. Okay. But now, when you have liver cirrhosis, your type 1 and type 3 collagen is now deposited in the space of this. Okay. So it's now going to accumulate in that space of this. Usually the space of this has type 4 collagen. But now when you have excess laying down from these stellate cells, you'll have it being laid even in the space of this. Okay. And I show you a photo so that it becomes easy what I'm communicating. So here is our normal liver. Okay, in this diagram. Let me show you nicely. This is a cell, hepatocyte. This is a hepatocyte. Yeah, this is a hepatocyte here nicely. And then here we have the space of this thing which is brownish. This is our space of this. Okay. And then inside now we have those cells, like the stellate cell that I'm talking about. These are quiescent, stable cells which are resting. Remember from your cell cycle. It will only wait for an activation, inaamuka inarudi kwa cell cycle. It starts going around the cell cycle. So at first it's resting here. There's a stellate cell. And then inside here, you have different delicate collagen. The one I'm saying type 4. In the normal one, this is type 4. Okay. Then here, this area is your capillary, the blood vessel here. And the lining of the blood vessel is the endothelial cell, as you can see here. Okay. Then there are usually spaces between each endothelial cell. So you can see the space here in between. I hope you can see my cursor, the space in between here. Okay. And then here you have your macrophage, the Kupffer cell, the macrophages which you find in the liver. So this is a normal thing. Now I say when we have liver cirrhosis, either hepatitis, it's going to activate an inflammatory process. So these Kupffer cells are going to produce cytokines, and the cytokines are going to act on our stellate cell and activate it to go back to the cell cycle. So when it goes back to the cell cycle, it's going to produce excess collagen and extracellular matrix, and it's going to change this collagen that is here from a type 4 to a type 1 and 3. This is what we are seeing here. Okay, the type 1 and 3 collagen being laid down using these lines here. So we are saying activated stellate cells, they become like a myofibroblast type of reaction. So they undergo a lot of proliferation, contraction, all those things. And they lay down collagen and fibrotic tissue. This is only one. Now they've been activated, they've gone back to the cell cycle, they are working, they're mainly like this. Okay. So what will happen is the activated is to some of the hepatocytes, some of them are dying. Okay. Dysfunction of these hepatocytes, and of note here, which is very important, is that some of these, you see now the way it is here, these sanocytes, these sanocytes, remember the function of the hepatocyte is all those things you mentioned, synthesis of albumin, synthesis of that. It's not able to do its function. And the blood exchange, gaseous exchange, etc. of solutes that was going through this hole. Okay, this gets obliterated. This space here gets obliterated with time over here by even this fibrous tissue, that the thing from the blood vessel, remember here is inside the blood. So that's how the function of the liver is deranged because of this part. Okay, so this is what I've been trying to say here. Okay, so we have the laying down of type 1 and type 3 collagen, okay, by the stellate cells. And so there's loss of the sinusoidal fenestrations, which is these two fenestrations here, and all this even between the hepatocyte and this nice space, it's all taken by fibrosis. Okay, Okay. So the capillarization of sinusites reduces nutrient and blood exchange. Okay. And with time, this fibrosis, this type 1, type 3 collagen, which is laid down, causes what we call bridging septa. Bridging septa. And so it will end up connecting portal tracts with veins. Let me show you now here on the photo. It will end up now, all this, because it becomes fibrotic, you'll end up having portal tracts connecting a tract, connecting with another tract, instead of this nice connection of portal tract with central vein, with the central vein. All this gets disoriented because now you're laying down different types of fibrous septa. Okay. And that's what happens with liver cirrhosis. Okay. So you have that bridging and connecting portal tracts to portal tracts with venal, central vein, different connections. Okay. Different connection. This is very important because that's the basis of liver cirrhosis. Now, as I said, there's a cycle that is created. So you'll have regenerating nodules occurring. So there's healing with fibrosis and there's some form of regeneration. Okay. So as the liver attempts to heal or repair itself, the few surviving hepatocytes usually form clusters. Okay. They proliferate into clusters. And remember, these nodules are surrounded by fibrous tissue. Okay. Of a nice lobule or a macina. Okay, and by so doing also the blood supply that we saw, the vascular connections that we saw, hepatic vein, central lobular vein, all that is taken away. And that is how even the function of the hepatocytes becomes insufficient. Okay, and that's the consequence of the liver cirrhosis. Okay, yeah. So this is what I've already showed you that. So the last part is just the architecture or the characteristics. Then what do we see? So the combined effects of all that, we will see bridging fibrosis. We have seen that with the laying down of collagen. We'll see the regenerating nodules as the liver is attempting to resolve. Then we'll have a distorted vasculature. Okay. With all this, that normal function of the liver gets diminished. All those things you were mentioning about steroid hormone, something, storage of vitamins, detoxification, deamination, all those is lost. All of them. Okay? Yes. So these are the major consequences because of obstruction of the blood flow, the normal blood flow through the portal system. Okay, which leads to increased resistance, and so you'll have, what you call portal systemic shunts, where you'll have insufficiency of the hepatocytes. Okay, so you'll have, because of that distorted architecture, you'll not have the normal functions of the liver. Clotting will become a problem. Synthesis of albumin, people will have edema causing. You can't. Steroid hormones will have a problem. People having issues, females having amenorrhea, gynecomastia. Those you discussed more of them even in chemical pathology. You'll have deamination is not occurring, so you have accumulation of ammonia, and which can go to the brain and cause encephalopathy. Okay, then you'll have patient having jaundice because there's obstruction of the flow of bile. Okay, because of that architecture. Okay, and then also the fact that the liver can't conjugate. Okay, so that's what usually happens with the liver. That's the pathogenesis. Okay, so these are the characteristics that I've mentioned, which is here. The fibrosis, regenerates the bridging bands, fibrous tissue or scars, which will link now portal tracts with another tract, and portal tracts with the terminal hepatic vein, the central vein. So the strands now cause portal to portal, portal to central, central to central, that's what we call the bridging fibrosis. So the nice thing I told you at the beginning is lost. Okay. Then you form these nodules, parenchymal nodules, containing the hepatocytes, which are surrounded by fibrous tissue. Then the disruption of the normal architecture and the blood supply. Okay. Yes. So those are the characteristics, the summary of the characteristics. Okay. So this is a thing I'll give you. You go read. It's a summary of what I have said. And the advantage of this summary that I have just said is that it gives you the pathogenesis and the complications. Okay. I like this summary because even when you're in the, relaxing as you're going home, you can have a look at it and it gives you a big picture, or even just before exams, you can just look at this and it helps you. Okay. So here at the topmost will be the agents, the etiology. Okay. Then regenerating capacity, overrides the regenerating capacity, you end up having fibrosis. Sometimes if you remove the underlying and there was just mild heal. But now when it's chronic, you'll have cirrhosis, irreversible formation of fibrosis within the hepatic cell, and then there's the hepatic cell regeneration forming the nodules, impairment of the normal function. It's nodular and shrunken. If you see it on the ultrasound, then increased stiffness on when you're doing certain tests, and then diffuse fibrosis with the nodules. Okay, then now that will lead to resistant blood flow. You end up having portal hypertension, which I'm going to discuss shortly. We can have hepatocellular carcinoma, okay, because there's the inflammation, the continuous inflammation will cause genetic changes, epigenetic changes, which make it now become carcinogenic. Okay, okay. So you have oncogenes and mutations occurring. Here you get hepatocellular carcinoma. Then insufficiency. The normal synthesis of coagulation, so you'll have high levels of your INR, for example, or then impaired metabolic toxins, hepatic encephalopathy. You get all that because of the brain and asterixis. Then coagulation, conjugation of bilirubin is not occurring, so you end up having jaundice. Okay, yeah. So this shows you a summary of everything. Okay, so it's a very nice slide for your revision. Okay, yeah. So anyway, let's just go back to our pathogenesis and see the last part after pathogenesis is our morphology. What do you see in that liver? So the liver becomes small and firm with nodules. Okay. Now, nodules can be small micro nodules, which is less than 3 millimeters, a classic presentation of alcoholic liver cirrhosis, or it can be big macronodules, more than 3 millimeters, which is more common with the other type. Then you'll see distortion of the vasculature. Then microscopically, we'll see the fibrous nodule beginning, and then variable inflammation depending on the cause or at what level you're seeing this. So I show you those photos now of the growth. So this is very beautiful normal liver that you see in the butchery, and this is the histology. You can portal vein and then the tracts, the portal triads. So the tracts are going like this. Now on this other side, you see a cirrhotic liver. There are multiple nodules here like this, small nodules, and these are we always put a ruler to measure. So these are the nodules. Take this, look at it on the microscope. This is what you see. Okay, like that with a bit of inflammation. So that's how we see it. Okay, so it's surrounded by fibrous tissue. Close up, look. You can see the nodules here like this. There's a nodule, there's another nodule, another one. Okay, this is how the liver will look like with cirrhosis. Okay, here I show you there small nodules. As you can see them, the small things like that. For the micronodule, like in alcoholic liver, as you can see. Okay. loss of architecture. If you compare this and our original, this one, this is our nice architecture on histology. You can see the small lines, the cords, the tracts as they're going down, and then the central vein and your portal triad. So you compare that to a fibrotic liver, you don't see that architecture completely gone. So what you're seeing are nodules. You can see here, these are regenerating nodules, then this fibrotic tissue in between, another nodule regenerating tissue in between, another. When you have these, the normal function of even that hepatocyte, some of them are dead, others are tried, they don't get enough blood because it's all gone. You know, the nice one that we had seen earlier on. So you'll end up having the function of the liver deranged. It will not be able to synthesize albumin. It will not be able to do deamination of, ammonia and other toxins. It will not be able to synthesize your, help with the metabolism and synthesis of your steroid hormones, etc. So that's why you have an abnormal liver function too in liver cirrhosis. It's a chronic thing. Unless, you do a liver transplant, how will you manage such a case? And it's all gone like this, Yeah. That photo of the same normal liver nicely, you can see your central vein will be here, and this is a triad here. Then you see the cords, the lines that are going down like this. Now look at a cirrhotic liver after hepatitis infection. Look at the nodules here. This is fibrosis in between, another regenerating. You have lost this whole nice architecture. Same here. This is a fatty liver. You can see the small holes, clear cells. These are fat cells, vacuoles, these ones. Okay? So you've lost all that. It's all gone. Liver cirrhosis. So we look at the pathogenesis, looked at the morphology, okay, of all of them. I repeat the same, okay. So now we look at the liver function, the abnormalities. If the function is not occurring, how will the patient present if they have liver cirrhosis? And I pause there and ask, what are the clinical presentations of a person with liver cirrhosis? I'll make it easy. You've done hepatitis, etc. Just what is the presentation of liver failure? Because when you have liver cirrhosis, the liver has failed. It's not doing its functions normally. But patients with liver disease, how will they present? Patients with liver disease, what are the clinical features, the signs and symptoms? Can you start typing? 1 minute only. Clinical features of liver disease. Yes, keep typing. I saw Nyango has already started. Jaundice, very correct. Start typing. So jaundice, dark urine, okay, of course, depending on where the obstruction is, correct, abnormal swelling. In cirrhosis, the liver becomes small, but unless you're saying abnormal swelling as ascites, Julius, I don't know what you mean by abnormal swelling. Because the liver usually becomes, we will not get a hepatomegaly as such, it becomes contracted. Yellowing of sclera, that is a jaundice. Ascites, correct?
Yeah, doc, when this patient present, they present with swollen stomach.
Wait, you can't speak like that and you're in that year. Swollen stomach. No umefanya anatomy, Juliet. How can you say that? You can't say that. If you're saying the abdomen is enlarged or swollen, that is ascites. Because stomach is not even related. We're in the liver. So how you're saying swollen stomach, that is like now a lay person. You can't say that. It's abdominal distension. That's what we call it. I think that's what you mean. The correct terminology for medics is abdominal. One could be the ascites, two could be a pregnancy. I'm just giving examples. Three could be, a tumor in the abdomen like that. But you can't say stomach, swollen stomach. No, no, no. That one is a lay person. If you're in studying medicine, I mean, and when I say medicine, I mean pharmacy. Like it's the same. There's no difference between us, we are a doctor. You can't say and those are differential. So in liver cirrhosis, that's what happens. Okay. Yes. Yeah. Okay. So somebody else has said jaundice pain on the right upper right belly area. Hey, you guys, belly. I'm just now wondering. Saying the word belly is TikTok. In medical school, in College of Health Sciences, you can't say belly. You people did anatomy. You have description of the abdomen. So we usually describe our abdomen. I'll send you to a book called Hutchison's. You'd see how you describe the abdomen. You can divide it into 4 quadrants or 9 quadrants and describe each thing in a quadrant. So when you say, like, the liver is usually in the right upper quadrant, that's why it's situated. So when you're describing, you have to say in the right upper quadrant. We can't use the word belly in medicine now. When you're an actual medic, you can't say belly. You have to say the actual. Okay. So check about how you describe the abdomen. Okay. And organs. Please just have a look at that book. It's called the Hutchison's Clinical Methods. Okay. Yeah. Swollen legs. You can't say swollen legs. You'll say edema. Hey, you guys, your language is, and yet you've done liver function test also. Yeah, you say edema like Timothy. You don't say swollen legs. You say edema. We already did general pathology and described. It's not acceptable. Like if I'm marking an exam and you're writing swollen legs or I don't know belly, I don't give you a mark at all. Not just me, all of us, because you're a medic. There's a difference between you and somebody. You guys, you're doctors, so you can't say like that. And I expect somebody doing community health saying the same thing. I know. Sasa hapo leo imekataa. So I refuse the terminologies. You have to use the actual terminology. And so I send you to Hutchison's. In fact, now you'll make me Hutchison's clinical methods. I even have a soft copy of that book. Now it's there online. If you Google, you will find it. I thought wewe nini watu. If somebody heard what you're saying, you'll be thrown out. Let me see whether I had Hachi. It's called like that. Hutchison's clinical methods. Okay, mine is an old one because it's a 22nd edition. Soft copy, it's there. Okay. So you'll go and look for it, Hutchison's clinical methods. And it shows you, general assessment, how you look at even terminologies and ethics. Okay. I've just looked and seen I have it. Wait. Please, my people. Okay. Let's use the right thing, the right words. Okay. Francis says CNS symptoms, of course, confusion and etc. Now, the best way I usually do it when I'm talking about clinical features or clinical presentation, I do something like a head to toe, like the same way you examine your patient. If your patient is there on the examination couch, you usually do a general exam head to toe, then you go to the actual system that is affected. Okay. So I show you with a diagram the same way. So head to toe like that. So you'll start from the head and see the different signs and symptoms that the patient can have. Just as we were told in the chat box, neurologically they can have hepatic encephalopathy. So you start from there. They get confused, etc., because of excess ammonia and toxins. They may have peripheral neuropathy also. That's neurological. They may have asterix. They have certain tremors and deliriums. You'll check, just Google some of these ones. Then if you move down to the skin, okay, let's go to this side. Gastrointestinal, they may have just general things of anorexia, dyspepsia, vomiting, etc. They may have changed of bowel habits. Then they may have the dull abdominal. You see where the liver is? This is the right upper quadrant. So you may have some dull abdominal pain there. Then they have fetal hepatitis. You go and Google all these things to understand all of them. You may have, when they get portal hypertension, they'll have varices, esophageal and gastric. They may have gastritis, hematemesis, vomiting of blood, then hemorrhoids. Okay. Then, because of the function of steroid synthesis and all that, females may have amenorrhea, they'll have testicular hypertrophy, the male will have gynecomastia. These are the things you did in chemical pathology. I'll not go back. These are things we discussed there. And impotence. So go back to your notes also, because they show you all that and describe reasons. Then in the skin, you end up having the jaundice that we talked about. It could be in the sclera and on the skin, etc. Spinal angioma, the blood vessels, when you look at the skin, they look like a spider web. Okay. Then because of the portal systemic shunting, you'll have caput medusa. I'll talk about that in portal hypermegaly and all the blood being congested in the liver. You may have a cytopenia, low levels of all those cells. Okay. Metabolically, you may end up having deranged metabolic the electrolytes. Cardiovascular, you have fluid retention. First of all, you're not synthesizing albumin, which is important in your extracellular volume maintenance, etc., and intravascular. So you end up having edema, okay? Fluid retention, the peripheral edema and ascites. So the ascites is what you're saying at stomach swollen. Where? It's abdominal distension. Let's use the correct words. Don't say lower legs swollen, you say edema. Okay. Summary, maybe if you look at your, not Hutchison's, your Robbins, it will describe further. Okay. And I'm sure it was mentioned when you did hepatitis as how the patient will present. Okay. Okay. So complications, which some have mentioned in the previous, and I'm going to have 5 slides of portal hypertension. Another one is hepatic failure. We have seen that they will not do conjugation, so you'll have jaundice. They'll not synthesize albumin, so you'll have hypoalbuminemia, which leads to edema and ascites, etc. You'll have no coagulation factors being synthesized, so you'll have a coagulopathy with a prolonged prothrombin time. Okay, I say that because I know you've done hematology, so you understand. You may have hepatic encephalopathy because there's no deamination. The toxins are not being removed, so they're just getting into the brain. You may have infections occurring, and the commonest is spontaneous bacterial peritonitis, okay, within the peritoneum, because they are there. You may have renal and circulatory derangements, where we have hepatorenal syndrome or hepatopulmonary syndrome. You go read those ones. I think they're also covered in chemical pathology. I know that's why we cover them, these two, okay? Then malignancy, the hepatocellular carcinoma. So these complications, I'll only discuss portal hypertension and hepatocellular carcinoma. The others are like what you discovered in your chemical or clinical chemical. So we'll go to portal hypertension. So I first pause there and ask whether you have understood about the liver cirrhosis. We're covering the pathogenesis. Then we looked at the morphology, both grossly and just patient presents. Then we looked at the complications. Okay. So let's discuss portal hypertension. Now, before I even say much about portal hypertension, remember when we were doing the different types of hypertension? You can have pulmonary hypertension. Now we are discussing portal hypertension. So you have to differentiate all those. So for portal, we are in the portal system. Okay. And so for calculation, different from when we look at the other portal hypertension, the other one. Okay. So definition, what's portal hypertension by definition? It's persistent pressure. Okay. Increase, persistent. It's just increasing pressure gradient greater than 5 millimeters of mercury when you measure. Okay, greater than that. For it to become clinically significant, where patients will present with signs and symptoms, it's when this pressure gradient is above clinical. Okay? So the portal vein, how do you get the portal vein? I like showing by pictures. This is the portal venous system that we're talking about. Superior mesenteric vein, okay? As you know, now here it will be intestines, etc. So you have your superior mesenteric vein, okay? Of course, here is your pancreas behind it. Then superior mesenteric vein is one of those. Then inferior mesenteric vein comes and joins here. Then you have your spleen. This is the spleen. So you have your splenic vein coming like this. So the joining of your splenic vein, your inferior mesenteric, and your superior mesenteric come and form the portal vein. Okay, this portal vein then now comes and enters into your liver. Okay, so in the liver you'll have the left branch and the right branch. So these are the ones that are circulating. They are the portal system that we were talking to. These things like your umbilical vein. Look at your left gastric veins which are coming from there. There's a reason why I'm telling you to remember that. Okay, but this is a portal system. So we are saying that there is increased pressure in here. Okay, in here. Okay, and that is what we're calling high as it's going here. So you have to look at things that would make it increase, either things from here, to make this portal pressure to increase. Okay, but you have to understand anatomically what is portal venous system. This is it. Okay, yeah. So the portal vein is formed by the union of the superior mesenteric vein and the splenic vein, just posterior to the head of the pancreas. Okay, usually the portal blood flow is about 1,000 to 1,200 millimeters per minute. The normal, when you have not distracted anything, that's the normal. But we will see as we are going on, when you have a disease process and this pressure is high, changes occur. Okay, this is just normal and definition. Yeah. So which are the things, what are the causes of increase in this portal venous pressure? What would increase the pressure here? Now, easy. It can either problem coming from this side of the liver because of the spleen, because of the splenic vein, as we said. Could be things coming from here, things within this okay, before it reaches here. It could be things within the liver itself, high portal pressure, or it could be things after the liver. You remember things within the heart. That's how you look at the etiology, which is my slide here. The causes of portal hypertension here. So this is the portal vein. So it could be things prehepatic, things before it gets here. And these are things either the vein itself, the portal vein here gets a thrombus, or the splenic vein, which is forming the spleen itself having here, this spleen itself having a splenomegaly, okay? Or certain fistulas within the mesentery, these mesenteries, okay? A fistula is a connection between one epithelia with another one, okay? So this is pre-hepatic, before it gets to the liver. Then there are those things within the liver, diseases within the liver. Good example is what we've just discussed, liver cirrhosis. Others are like infections like schistosomiasis, infections like hepatitis, okay, or just veno-occlusive diseases could be rising cholangitis in here, and etc. I've given you a long list here. Or another cause could be after the liver, post-hepatic here, as it's going here. Could be right heart failure, could be regurgitation, could be constrictive pericarditis. All those things could be covered here. So all those things will cause pressure in this portal system to increase. That's all we are saying. Yeah. Yes. So the pathophysiology, what usually happens for that? So when you block, depending on whichever etiology is here, like today we are discussing cirrhosis. So when you have liver cirrhosis and you have now formed those nodules, the architecture is different, you'll have increased resistance to flow of blood. Okay, there's a lot of resistance because now there's blockage. Okay, so the increased portal vascular resistance leads to gradual reduction in the flow of portal blood to the liver itself. Because you know there's resistance, there are nodules being formed, the vasculature has changed. So now the portal, the reduction in the flow of portal blood to the liver itself. And then simultaneously, there's the formation of collaterals. You know, just like in the heart, if this area you think about a river, if or how rivers drain into the ocean or a lake, you see there are many tributaries that can occur, whether there's a blockage, etc. So it's the same here. Collaterals will form. Okay, so they'll allow portal blood to bypass systemic circulation. Okay, and those are the things we talk about in portal systemic shunting. Okay, so the and for this collateral between the portal and hepatic vein, the one I talked about, becomes very high at about 10 to 12, the shunting occurs, or blood now moves back to the systemic circulation. It moves from portal circulation. So what are the things that can lead to that? So as I said, there's increased resistance to blood flow, portal blood flow, and then later on there's increased portal blood flow inside there, just floating inside. So what are the mechanisms? First, like in liver cirrhosis, structural changes. The architecture is changed. We have fibrosis and nodules being formed. Okay, so the normal vasculature is lost. Functionally, because of the toxins and the changes that are occurring, there's destruction of the endothelium. Okay, so the endothelium has chemical mediators. So some of those will produce like the vasoconstrictors. Okay, and therefore they will increase the tone, the vascular tone inside intrahepatic. Okay, another thing that can occur is a splanchnic vasodilation. What is splanchnic? You know, blood supply in your GIT, or in the abdomen. The splanchnic blood is, blood going to the gut, the stomach, the intestines, the spleen, all those. That is a splanchnic blood supply. So we are saying when you have this portal hypertension, there's vasodilation of those areas. So there's vasodilation of the things in the stomach, in the intestine, that whole splanchnic area. Okay, so the portal hypertension, what it does, it triggers release of nitric oxide, etc., within the intestines, the gut, etc. Not different from what was happening in the dysfunction in the liver with the toxins. This is just another reaction. Okay, and what will happen? You'll have dilatation of the arteries within that splanchnic area. Okay, and what will happen now? More blood is going to flow within the portal venous. Here now, oops, here more blood. You see, we're seeing here there's dilatation of all these ones. These ones, whether they're in the spleen, if the stomach was here, to show all that, the intestine. So more blood is now going to flow again here. So first of all, you're having resistance, more blood is just coming in. So it increases the problems further. Okay. Okay, so just 1 minute. Okay, sorry about that. Okay, so I was talking about this planning vasodilation. This, so more blood now is coming in, and there's resistance. Okay, so there's an increased portal venous flow. This is what we were saying. There's increased resistance and there's an increased portal blood inflow. Then collaterals now form. Like I said about a river, they look for tributaries. So the blood seeks alternative routes, back to the systemic circulation because they're overwhelmed in the portal circulation. Okay, so that's how they end up in portal. The normal way it goes all the way and goes back to the heart. Now it comes out and goes to the systemic normal circulation, moves from the portal venous circulation. Okay, and those are the ones we see as varices, etc. I'll show you a photo of that. Then there's also the hyperdynamic circulation. Because of all this increased blood and all that, you'll have an increase even in the cardiac output, okay? And reduced systemic vascular resistance. Remember, the resistance is increased in portal, but systemic vascular is reduced, okay? And all this now will lead even to the ascites that we see and even the hepatorenal syndrome that we see, because it will affect the renal system, pulmonary, and ascites, okay? The things I showed you in the diagram earlier. And this is a summary of that. So we have a cirrhotic liver, for example. Architecture has changed, causes increased resistance. Functional, where you have endothelial cells producing different chemical mediators. So there's increased vasoconstriction, increases the resistance. So you end up having the portal hypertension. In reaction to that, there is also the portal hypertension causing splanchnic vasodilatation. Okay. And because of that, increases blood flow back to the portal system, okay? The increased portal blood inflow back there, okay? Then also the splanchnic vasodilatation causes a hypovolemia, low volume in the systemic, okay? And because of the hypovolemia in the systemic, it activates even things like renin-angiotensin system so that you can retain sodium and pull more within the systemic, eh? So it will end up having, the increased cardiac output, changes in the cardiac index. Okay, so and this again increases also the portal blood flow. Okay, so it's a continuous things going on, and remember it's a chronic disease, so this continues happening throughout. So you end up having a continuation of increased pressure in the portal system. Okay, yes, and as I said, because of that, they try to form collaterals. You want to escape this pressure. So how do they escape? These are examples of how they'll escape. Okay. So like, for example, you remember the arteries I showed you, the gastroesophageal, the short gastric arteries, etc., that were coming here in the spleen, these ones. So you'll have shunting. Instead of the blood going this way, it will shunt and come here. Okay. Retroperitoneal, it will come and go to the short gastric arteries like that. It can go to the gastroesophageal arteries. So you'll end up, no, instead of going to the portal system, it goes to systemic gastro. So you end up having esophageal varices. And sometimes people can bleed to death through rupture of these esophageal varices. They can bleed to death. Okay, then you remember the umbilical vein. So instead of going to the portal system, it goes to the umbilical vein and it comes here to the umbilicus. It forms something we call caput medusae. You'll see near the umbilicus, you'll see distended blood vessels around it, just distended with a lot of blood around it. Okay, that's um, that will be the caput medusae that we talk about. Okay, I talked about the retroperitoneal, then you go to rectal hemorrhoids. You also have, now instead of it going back, you remember we had the inferior mesentery. This is for superior. This is the inferior mesentery. You'll have the blood going to the systemic blood flow here and forming the hemorrhoids, the dilated vessels we see, the piles that you people say in lay language. Okay, so these are different ways of portal systemic shunting. So usually, normally 100% of the portal venous blood can be recovered. You know, this one. See, this is a portal vein now. You can be recovered from the, here is the liver where it will be. It gets in, then it goes to the central venule, which is the hepatic vein. All of it can be recovered as it's going to the inferior vena cava in a normal person. But in a cirrhotic person, we'll only get 13% or even lower because of alternatives. So they end up having systemic shunting. Okay, so only 13% will be discovered in the hepatic venule. Okay, because all the others, the 95% forms these collaterals that we are seeing in this picture. And this is our nut point here that we were saying. Okay. In portal hypertension. So clinical features, we're just going to stress about the effects of the cell, the esophageal varices. Okay. Those ones can actually cause bleeding, hematemesis, and if they're in excess, you may end up having hemorrhagic shock. I know when I say that, you can have melena stools because of, bleeding in the, you're blocking, there's too much pressure in the splenic also. Okay, you may have dilated abdominal veins, caput medusae, because of the blood shunting into the umbilical vein. So this is a caput medusae. So you see dilated blood vessels around the umbilicus. They'll have ascites, which is now what we call distended abdomen. You call it distended abdomen. And then you have your rectal varices, the hemorrhoids. Okay, so these are examples. So complications that you can have, they're all that you said there. You can have ascites, okay? You may have portosystemic shunting where you'll have the caput medusae. I've talked about the rectal varices, the esophageal varices. Because of shunting of ammonia and toxins, you'll have hepatic encephalopathy. Then splenomegaly will cause a cytopenia, okay? Decrease red blood cells, decrease white blood cells, and decrease platelets because they all get lodged inside here. Okay? So they're decreased in circulation. And that's the end of portal hypertension. Breathe in and out and ask questions. I've noticed there's a gap in your chemical pathology or clinical chemistry. And so I'll send you to go back and read your clinical chemistry work. Eh? There's a big gap that I have noticed there. I'll figure out, I'm trying to see, there's a big gap. I don't know if I have any short notes that I can share with you for liver function. I'll look up for that. Then Faith, you can remind me. I can send you a few of, so that you for the liver, because I see there's a small gap in your liver function tests or biochemical assessment of the liver, which is done in clinical chemistry. Okay? Are you people there? Can you hear me? And we are many. Now we are 40. So we could be heading back to having something. Are you people there, Faith? Timothy? Julie, are you there?
Yeah, we are there. Are we going to discuss management?
Of course not. Mimi ni pathologist.
Okay, thank you.
But don't worry. At the end, like in complications which will have liver cirrhosis, I'll mention. But management, I can mention with you to you easily about management. Now, person with liver cirrhosis, you see how bad the liver is. Management could either be a transplant. You know, management should have come earlier before it became liver cirrhosis. But now that it's liver cirrhosis, you can only be doing supportive or palliative management. And I'll give you examples of in practice what because ascites can make them not to be able to even breathe properly, etc. So usually what we do, we just do an acidic tap. So they would come. I remember another men, Emo, all those men, they were my friends. Take an alcohol, everything. They come, the abdomen is, they can't even see their toes. They can't even breathe properly. And they just come and tell you, hey, doc, but siku mingi nimekuja unitoe maji. They tell you like that. So you put we'll use actually a cannula, the pranula, the green one. You put it in the abdomen nicely. Maybe I should show you a photo here. So the site is here. So you put it somewhere like here. They're lying down. Then you connect it to a urine bag because you don't want to, you cannot empty to dryness. And then you'll put, unless you, because they can collapse. So you put in a urine bag. Urine bag, I think usually holds like 2 liters. So you connect here, the needle, then the urine bag is somewhere over here. So you empty like 2 liters, then you stage, you empty another 2 liters, like 4 liters, just to make them more comfortable, the fluid to decrease so that they're able to breathe normally. So we'll do such things. Of course, if they're having a coagulation problem, you try and take care of coagulation, these complications, you try and take care of that. But there's no healing, complete unless you do a liver transplant. But that's a common thing that we used to do. They come, we help them with that as a major one. Okay? Yeah. But of course, you see, if it was hepatitis, there's nothing you can do now because you can't treat the chronic hepatitis because, of course, there'll be positive surface antigen, but the disease process had already started. I mean, even though you say you'll abstain from alcohol, the liver is already destroyed. Okay, so you're just doing supportive management for them, which I'll also mention again in liver cirrhosis. I mean, in liver tumors. Okay. If there's anemia, you manage it. If there are infections, you manage them. Okay. So we breathe in and out so that we look at liver tumors. As we wait, I can see maybe there are questions, you can put them around. Then we can mention about the liver tumors. Which tumors do you know? Which liver tumors do you know? Liver tumors, which tumors do you know of the liver? Other than the one I mentioned, the hepatocellular. Hey, no one is saying anything. Are you people still there? Today you're just quiet. Julius, what's the problem? Kevin and Timothy. Timothy A, Timothy B. Okay, Kevin has a question, sorry. He's asking, what is the prognosis of ruptured esophageal varices secondary to alcoholism? There are many cases of people being found dead, and people say, and I quote, wametapika maini. Oh, okay. Kevin, so there are two things here. They Mallory-Weiss syndrome, Mallory-Weiss, rupture of those two blood vessels around there, and they can vomit, with blood. But there's the one of actual rupturing of blood vessels. Imagine it's like your radial artery imekatwa, so you're just bleeding like that. So there's that main one. And I think when you say umesema umetapika maini, I think it's now the actual rupture of the varices. And we just go back to what we did in 3.1. Different types of shock. You can actually get a hemorrhagic shock. You can bleed, and then you remember you have about like 5 liters of blood, the one we usually have. You can bleed, by the time you're getting to even just bleeding and now you're pale, you're all white, you've bled like 4 liters is all gone. You'll get, the heart will fail, everything, you can actually die because of that. The different stages of hemorrhagic shock, like you're now on stage 4, stage 5, you'll actually die because of the bleeding. And I think that's what they mean wakisema you said ametapika maini. Okay, they've ruptured and they've just bled like that. So these vessels actually, these varicose vessels, slightly different from if you had a binge drink. The small for Frank, you wametapika maini, is that Frank one where they just get into shock. I know since there was nobody there to resuscitate or help or replace, and they were drunk, they just die. So that's what it is. The rupture of the varicose, esophageal varices. Esophageal varices, the rupture, correct. We've seen that. We've seen that, by the way. As I said earlier, that easily causes death. Yeah. Okay. I hope I've answered your question, Kevin. So I've seen people have mentioned Julius has given us cholangiocarcinoma, correct. We have hepatocellular carcinoma from Timothy. I don't know if it's Timothy A or Timothy B. Then we have hemangioma, again, correct. Also discussing a complication of it can be tumors. Okay, so we'll go to that and keep bringing the questions so that we can answer. Okay, even hepatocellular carcinoma, which is tumors, benign and malignant. So for benign, the commonest is hemangioma. Okay, and we'll have 2 slides on hemangioma. Then we have, benign tumor-like lesions like the the focal nodular hyperplasia, FNH, focal nodular hyperplasia. Then we have hepatic adenoma, okay? And we'll talk about hepatic adenoma again, 3 or so slides, and how it's associated with steroids, okay? So that's for benign. Then malignant, we have what you call the primary malignancies within the liver. Then we have metastatic, or is the most common. Okay. Then we have cholangiocarcinoma, hepatoblastoma in children. Then we have angiosarcoma. Okay. Angiosarcoma usually is because of exposure to carcinogens, mainly, the metals. You have your arsenic, you have your vinyl chloride. So you can get an angiosarcoma. Again, it's rare, but it's something that can occur as a primary tumor in your liver. Metastatic tumors to the liver. A lot of the common sites that's or colon. Okay, so you have but tumors within the liver itself, and those that are moving from a different site to the liver, which we call metastasis. So we'll have a few slides for benign, and then for the malignant, cholangio will be discussed in the next topic when we look at a bit of the gallbladder and the pancreas, okay, in the next class. Okay, so I'll just deal with a bit of epidemiology. As I said earlier, metastases to the liver are the most common. They're more common than even the HCC, the primary tumor in the liver. For the HCC, prevalence is increasing because of the different diseases like the chronic, in our setup, the chronic hepatitis B and C, okay, and also aflatoxins, which we'll see. In the Western world, because of obesity, diabetes, and the non-steatotic liver disease, more common in the middle-aged or older individuals, especially those who already had liver cirrhosis. And we'll look at those in detail. Angiomas is the most common, okay? And many times it's just an incidental finding. Okay, you are maybe going for a well check, different things in the hospital. We do an ultrasound and you find a hemangioma in the liver, not because it was bringing problems, unless it's increased in size, massive, causing an. Okay. I just summarize the etiology of the different tumors. Hepatocellular, we'll look at it in detail again. So we skip this column and look at cholangiocarcinoma. That some of the things that can lead to cholangiocarcinoma are your primary sclerosing cholangitis. Again, we'll discuss in the next class. Infections, like with the liver fluke, you've done microbiology and parasitology, so you're aware of the different. We look at each, but most of them, like your hepatic adenoma, is related to exposure to steroids. Okay. Then for hemangioma and the focal nodular hyperplasia, the cause is idiopathic. We really don't know the cause as such. Okay. So let's start, as I said, with the benign. So we'll start with your hepatic adenoma. Hepatic adenoma. Just 3 slides of it. Okay. So again, from the name adenoma. Adenoma is benign epithelial tumor. Okay. We did that in 3.1. So where do we find it? In about 95% of women of the childbearing age, again, exposure to steroids. And these women who get this adenoma, they have a history of more than 5 years of using of oral contraceptives. Okay, most of them. Then for the men who get this, they have a history of using anabolic steroids. Okay, we find it's a spontaneous doing tests, etc. And the location many times it's below the capsule of the liver. And I will show you just shortly, grossly how it looks, okay? And sometimes of note is that during pregnancy, this may rupture. And I will show you that because below the capsule, this is your gallbladder where it was. So this is the adenoma. So you see, this is a capsule here. Okay? It can easily rupture. Okay, over here, especially in pregnancy. Yeah. Okay. As I said, it's an adenoma, so it's a benign lesion. However, when we get this brought on my desk, I have to really sample it because sometimes it could be having, so it could house a HCC in 10% of cases. Oh, sorry. In about 10% of cases. Okay. So that's why I'm saying I have to sample I have to cut small pieces to make sure I don't miss out the hepatocellular part of this. Okay, so this is how it looks. Very nice nodule here. Okay, has a bit of bile in it. Okay, can range from 10 to 30 centimeters. Very well capsulated. It's benign tumors. Okay, yeah. Many times it's on the right lobe. Okay, yeah. And the liver, as you can see, is normal. You don't have liver cirrhosis in this one. It's a nice liver. Okay, yeah, not cirrhotic. That's for your liver cell adenoma. Of course, management is you remove, excise. You just come in here and remove all of it. Because I know, Julius, you'll ask me about management. Easy. You just come in, you go to theater, and you remove this. It's benign. So you'll remove. And okay, that's for adenoma, hepatic adenoma. Go to hemangioma, which is the most common, okay, of the benign. Again, it's just an incidental finding. The patient is not presenting with features unless it's really big or it has ruptured, okay? It's more common in the adults than we see in the children, and more in women again than in men, at 75%. And then the in women, 10% usually enlarge when you do follow-up, because you just monitor them, okay? So they can become big. And our worry is that when they become big, they may also rupture, okay? Yeah. Many times we see it in association with the focal nodular hyperplasia, okay? And they become very big, they can form giants, which we call the giant cavernous hemangiomas. Very big, they're more than 10 centimeters. Yeah. And I show you a photo of the hemangioma here. So this is your nice liver, the one you see in the butchery. However, this is a nice part like this. But if you see closely here, there's like a capsule surrounding this area. Then inside it, there's a tumor. Okay, as you can see, this is a hemangioma. You can see blood, okay, hemorrhage inside. That's a hemangioma. Many times it's solitary, 111. Solitary is 1. Usually 2 to 4 centimeters, like if you measured from here till here. Although you can have very large tumors, even more than 20 centimeters, okay? So it's, as you can see, it's soft, red, purple. Okay, as I said, well capsulated, okay, circumscribed. Yeah. If you cut it, it loses us blood, will ooze out blood because it has blood inside it. It's a hemangioma, you know. So when we cut this and look at it on the microscope, this is what we see. Dilated, variably sized spacious vascular spaces. See here, these spaces here. These are all vascular spaces. High power, these are vascular spaces, very many. And they're all lined by endothelium. Some of them may have thrombosis like here. So that's what we see. Hemangioma. Again, management. I'll be saying management, Julius, don't worry. Of course, you just go and excise. You go and remove it. It's a benign. You remove it as it is like this. Okay? Yeah. So those are the only ones I'll discuss for benign. I'll only discuss those two. You can go read about focal nodular hyperplasia. I discussed the hemangioma because it's more common, most common, HCC. Okay. Cellular carcinoma. So 85%, it forms 55% of hepatic malignancies, primary, okay? That is coming from there. It's a major cause of death worldwide. Like in China, causes in 20 to 40%. In Japan, and even where we are now, sub-Saharan Africa, it causes death. I've seen that, okay? It's higher in blacks than it is in whites with a ratio of 4:1. Most people are 60 years and above with a cirrhotic liver, okay? Of course, now you can see the history. We could be alcoholic, causes liver cirrhosis, then eventually develops into hepatocellular carcinoma, okay? For ages of 20 to 40 years, if you see the hepatocellular carcinoma, it's not related to liver cirrhosis, okay? So it's non-cirrhotic, okay? And occasionally we'll see liver cirrhosis secondary to another tumor like the nephroblastoma or what we call Wilms tumor. Don't worry, we'll discuss it when we go to renal. Okay? Yeah. So risk factors are like the ones we saw for liver cirrhosis earlier on. So you have hepatitis B and infections, hepatitis B and C. We have alcohol. We have your aspergillus flavus, which produces the aflatoxins. We have exposure to the road trust exposure, androgens, tyrosinemia, tyrosins. The liver cirrhosis and its causes, as you can see here, glycogen storage disorders, hereditary iron overload, and an alcoholic fatty liver disease, alpha-1 antitrypsin deficiency can be longer than this. Many things can cause liver cirrhosis. I mean, hepatocellular carcinoma, you go and add. Yeah? That's so for the pathogenesis, what usually happens is, for example, there's exposure to the toxins, okay, like either the inflammatory, hepatitis B, alcohol, aflatoxins, okay, and they lead to a liver becoming cirrhotic, as we can see here. But there's continuous oxidative stress into this liver that is inflamed now, which is trying to is coming in because of the injury that is continuously occurring on your hepatocytes. Okay, so it gets to a point that the liver is not able to control. There's inflammation going on, and now the liver undergoes adaptations, different forms. So you'll end up having dysplasia in the liver, okay, because of this continuous exposure to the stress. And then you develop epigenetic carcinogenic areas, okay, because of that continuous exposure. So it moves from a low-grade dysplasia to a high-grade, and eventually other things, exposure in the environment, changes in the cellular components of the liver, okay, all those that we talked about in carcinogenesis, ending up having hepatocellular carcinoma, okay. So those are changes that would occur because of the chronic exposure, okay. So how do we see a liver which is having the hepatocellular carcinoma? With an open eye, you'll see a single mass or multinodular lesions, masses, or just diffuse infiltration. There are different methods that it can occur, okay? The color of these masses will be yellow-green, okay, due to bile that is there. And sometimes you will see, because you're able to see grossly the blood vessels, you'll see it invading to the blood vessels, the portal or the hepatic vein. You'll see it invading grossly, okay? Microscopically, you will see your hepatocytes that are abnormal, malignant features, okay? So many times on the big picture, instead of having the nice chords that you were seeing, the nice lines that we were seeing, they're not just two lines, now they become like 6 lines, okay? That's what we call trabecular pattern, okay? Then you may have also glandular sort of forms, like forming an acini, pseudoglandular structures. Then the cells resemble hepatocytes, but they have pleomorphism, different shapes and size, okay? Could just be mild, but you can see it. Then a good thing that we always see is the presence of bile production. The green, you're seeing a greenish coloration too, the bile production. You may see invasion in the blood vessels, as I mentioned grossly also. And I'll show you photos of that. Before we go there, let me show you the photos. So as I said, this is, you can have multiple nodules, okay? So this is a nice liver, but as you can see, this one is a fleshy tumor. All this is a tumor. There's a bit of remnant normal liver, like where my cursor is here, but all these multiple nodules is tumor. You can see this one here. You can see all this. This is tumor. It could be unifocal, as I said, it could be multifocal or diffuse. So as you can see here, it's multifocal. It's everywhere. And near the capsule, you're just having normal. But you can see it has not penetrated the capsule. See our capsule, you can still see it here. Okay, but the tumor is this one. Okay, yeah. Again, we see another photo. For this one, the tumor is right here. Okay, you can see the tumor right here nicely like this. Okay, pale tan white tumor here with hemorrhage inside. As you can see, hemorrhage. There's a tumor like that. The real one pushing even into this. Okay, looks like an adenoma which was here. Okay, then you have, this is liver. You can see this liver is not normal liver. It's cirrhotic. It has very many micronodules. It's a cirrhotic liver. Okay, so this patient had liver cirrhosis. Then it developed developed a hepatocellular carcinoma. Okay? And then this is how we'll see now that under the microscope. You have to cut this and look at it in the microscope. This tumor, as I said, you will see multiple trabecular pattern. Remember in the first picture we were seeing just lines, but if you see this, it has more than one. The cells are many, 1, 2, 3, 4, all this. It's like a plate of many cells in one area. This one is trying to form an acini here, as you can see, with like a lumen in the middle. Then this is the acini forming here. Same with many trabeculae here. So it forms things like that, okay? To try to form trabeculae, form glands like that when you have the malignancy. So this is this when we looked at it under the microscope, okay? So it has liver cords that are much wider than the normal liver plate, and that is usually just 2 cells thick. You can see these ones are more than 2 cells thick, okay? And you don't see any normal architecture here in this picture. Remember the one I showed you at the beginning, you don't see any of that. So that's how the hepatocellular carcinoma will look like, okay, morphologically. This is what I was describing, both gross and microscopy. So clinical features, many times when it's tiny, it will be silent, no presentation. Then general symptoms, they'll have weight loss, of course, tumor cachexia. They'll have malaise, anorexia. They may have pain in the right upper quadrant where the liver is situated. They may have a hepatomegaly if it's big, okay, the mass. Okay. Then signs of tumor-related things like fever, if there are inflammatory cells being, chemical mediators being produced. Then they may have sudden abdominal pain, especially if there's hemorrhage into the tumor. Then they'll have elevated alpha-fetoprotein, okay, as a tumor marker. You discuss tumor markers again in chemical pathology. So alpha-fetoprotein is one of those for the liver. Of course, you'll see it also in germ cell tumors, but liver, it's there, okay? Yes, okay. So diagnosis, you'll do a biopsy, of course. I know someone will ask me, now when you have like this, what do we do when you want to do? This one is, of course, somebody who is dead now we have removed, or maybe we're doing a transplant, but I'm just saying dead. But now when the person is living and you want to make a diagnosis, so we usually do ultrasound-guided biopsy. So you'll come in with the biopsy needle and take it inside, okay? So and come and pick samples from here. And then that's what I'll look at under the microscope like this. So you'll do biopsy-guided, ultrasound-guided biopsy. So we'll come and target where the tumor is because you're being guided. Then you take the biopsies from there. Then we look at them and you bring to me, I look at them under the microscope, then I will tell you whether it's a metastatic tumor or it's a primary tumor of the liver. So that's how we do diagnosis. Biopsy. Other additional blood tests that you can do is the alpha-fetoprotein as a tumor marker to see whether it is increased. Then you do imaging, of course, like the ultrasound, you'll do CT scan, MRI, etc. Then you can do blood tests, which will show abnormal liver function tests, of course, because the liver is not functioning normally. It's diseased. Management, you do treatment, you do, if there's a small one, you do surgery. I thought I even broke it down. Yeah. General management. So surgical resection for solitary small tumors, and the liver is not cirrhotic, like I show you. That's a cirrhotic. Oh, I didn't have a picture of that. Assuming the lesion is this one, and this liver was not cirrhotic, it was normal liver, you can come in and remove this. You just do this and leave the normal liver here. Okay, I thought I had a picture. Okay, that's what we mean by that. Liver transplant, okay, especially for early stages of HCC, okay. There's usually a criteria of how they discuss that. I'm not going into those details. Then you can do local ablation, okay, for the small tumors, like the one I was saying, you sort of burn out, okay. Then palliative care, especially, it's a cirrhotic liver with that tumor, you just do palliation because it's non-curative. So you do targeted therapy, immunotherapy, manage the symptoms. Then for surveillance, very important. That's why I put this one here. So all patients who have cirrhosis, liver cirrhosis, and at high risk of, because they have hepatitis B. Usually you've done microbiology, so you know how you test for chronic hepatitis infection. So those are high risk people. So if you have somebody with high risk, you can monitor them. So you'll do an ultrasound, then you'll check with the alpha fetoprotein, okay, every 6 months. You do ultrasound, look at how the liver is, and you take your alpha fetoprotein blood test every 6 months, okay. So you can do surveillance so they don't. That's the end. Okay, that's the end. So you're going to read on hepatoblastoma. I didn't discuss it. Angio will be discussed in biliary tract. Then this is the gap I have seen. You have to review the liver function tests. I thought you will just go look at your notes in clinical chemistry. I think you have notes. You'll have to look at that. Then read on those syndromes. The way I said, hepatic failure or hepatic encephalopathy, hepatorenal syndrome, hepatopulmonary syndrome. That's the end. So you usually, I like when we're discussing liver cirrhosis or liver disorders, you relate it with your clinical chemistry. Usually we like to do clinical chemistry or chemical pathology concurrently with systemic pathology, because now you're able to understand the gaps are picked easily. It's just that you people did yours earlier, so you will have to go back and see the gaps. You see, like us now, we expect you to be knowing chemical pathology too. So even when I'm asking questions, I can tell you to describe how you analyze biochemically functions of a liver. I expect you to be knowing. Yeah, after we've discussed even the disease processes. Okay, any questions? Today you are very dull as a class. I don't understand why. Extremely dull.
We're okay. We're okay.
Yeah, I don't understand. Ama ni Christmas.
Christmas bado.
Unajua what? See, next week, like from Wednesday tufanye online ndivyo.
Magari za kwenda Western imepanda bei.
Lakini nimeona hata Mombasa tumeongezewa train, watu wa kwenda Voi, the train imeongezwa, there's an extra train. So yeah, but anyway, I understand. Kama hujabook mapema kwenda Western itakuwa shida. But we can negotiate.
So Doc, can you talk about the asides? Where I grew, they used to say that our wagonjwa wamerogwa. So say that in liver cirrhosis there is atrophy rather than hepatomegaly.
Wait, I did not say, I have not mentioned atrophy anywhere. Please don't use those terms. And just
yeah, I'm talking about liver shrinkage. The liver shrinks rather than enlargement. That's what I'm trying to say.
Yes. Oh.
So if the liver is shrinking and there is this formation, I just want to understand how the ascites comes about. Is it because
you
of...
meaning ascites? You mean ascites, you mean ascites?
Yeah.
Ascites, okay, I get what you mean.
Distended, and forgive me for the other term, hiyo ni lugha ya mtaa. Because huwa wanasemanga tumbo imefura. So
tumbo ni abdomen.
Yes.
Hata nakwambia tumbo imefura, tumbo inakwanga abdomen, ni kwangi stomach.
Yes. So is it because of the portal hypertension, because of now there is fluids leaking out into the peritoneum, or how does that process come about?
Yeah. Now I'll take you back to 3.1. In 3.1, one of the reasons why we were having edema, for example, is because of albumin, low levels of albumin. You remember, albumin is what helps you to pull it back. So when you have low levels
Yes.
of albumin, then you'll have accumulation of fluid in the extracellular space, isn't it? So that's one of the
Yes.
reasons. Liver is macronodules, those producing or synthesizing albumin. So you have already have low albumin in your body. So fluid is going to be, it's not moving out. So you're having a chronic edema in even those spaces. So you'll have ascites. You even have an effusion. That's one of the reasons. It's because the liver is not synthesizing as it should. I'm actually trying to get you a slide. Let me end show, because there's a slide for, usually I tell you people to go read, but now you'll make me put it down. I think even this one I must have mentioned for ascites. Mm, I didn't. Okay, I know I usually have a slide for ascites, which I don't show you. Where is portal hypertension? Mm, okay, this is just like a summary. Yeah, there's the one I've told you about, low albumin causing the ascites. This is the ascites, tumbo imefura.
Ye-
Okay,
Yes.
so one of the other things, you remember in portal hypertension, in cirrhosis, we talked about splanchnic dilatation, where you have an increase in nitric oxide being produced.
Yes.
With this vasodilation, it decreases the blood volume, because now blood is going to one area, it's going to maybe the stomach, those areas. So the normal systemic volume is also decreased. Okay. And what will it do? It will going to activate, the kidney senses that, we're not getting enough blood in the kidney. What do? So the renin-angiotensin system is activated. Okay. So that you can retain salt and be able to pull water because of the osmotic gradient. So this is activated. Okay. So that you can take care of the
Yes.
circulation, so you get a hypodynamic circulation, you retain sodium, and sodium, because of the high osmotic gradient, pulls water with it. Then renal vasoconstriction that has occurred, you're trying to say, leads to the ascites also. So there are different methods for the ascites. There's a low albumin because the kidney is not, the liver is not synthesizing. And then there's also this methodology, okay, that I have put across to cause this fluid inside here in the ascites. So that's the other way of the ascites.
No, I
Okay.
get it. I get it. I understand it now.
I didn't show this. I remember. Usually I tell you people to go and, I thought I wrote that question. I usually tell you people to go and read the pathogenesis of ascites in liver cirrhosis. And I think usually a thing I say. Yes. You see, I think I hid my slide. Usually I give you this as an assignment and tell you, read on the pathogenesis of ascites in portal hypertension. But this is the pathogenesis. That's this one that this one. Albumin, low albumin, the low albumin that causes even the edema. Yeah. So this is part of it. Okay.
Okay.
Yeah.
There, since the liver is regenerative,
Yes.
when the hepatocytes become injured and they start forming these nodules, if
Yes.
the causative agent is reversed, is the liver able
Yes.
to repair these nodules? So these nodules expand.
Now it depends. It depends at what level we are at. And I think I showed you that diagram somewhere. Maybe I moved too fast. I give you a summary here. If you look at this, you see the first place over here. This is
Yes.
etiology, the many things that are occurring. So if you say it's alcohol and you stopped it early enough, severe or chronic hepatocyte injury overrides regeneration capacity. But there's a time if it's just mild fibrosis, because all that, the injury and regeneration is occurring. So you end up having some fibrosis. So if it's mild fibrosis, which is coming in between the nodules. But it may be reversible. I put for you in this statement here. Mild fibrosis may reverse with treatment of the underlying cause, early and mild. But once it becomes now chronic, which now becomes cirrhosis itself, then you can't go back. You can't revert back. So there's that part. And yes, when it's very
Thank you.
mild, I captured it in this page. Maybe I rushed through this one. And as I told you, just have this as your small Mwakenya. Okay, then you'll just fill in gaps in this small Mwakenya that I put for you because it summarizes for you most things. Yeah. Unfortunately, people don't come for treatment. Even you'll not notice changes, eh? So you'll not be knowing that some fibrosis is going on. You unaendelea tu kama unaenda sherehe, and not knowing that you're building some problems on yourself, eh? Yeah.
Yes,
Sherehe.
nimekwambia kwetu watu walikuwa wanasema umerogwa, so they don't even I lost my cousin. I think she was 15 years.
What? Oh, 15.
Yes, and I think it was just this liver cirrhosis, but she was just at home. Because my uncle used to say kuna another uncle alikuwa amefanyia uchawi, so they could do some traditional manenos, but things didn't work.
Julius, this is what I suspect. I don't know. I'm just saying suspect because now we didn't do an autopsy, but I suspect, suspect. I'm just trying, to create, like cause of death or something in the 15 years to come out from amerogwa. If you look at my list here, like hepatitis, there are different methods of getting the hepatitis infection. So it could even be mother to child. Okay. So maybe
Yes.
the child got it from the mother. I'm just saying, for example. And it will take a time for it to become chronic and develop like even cirrhosis, and then someone dies. You're getting? So it could be, because I remember I had a patient, a 26-year-old lady. That was sometime, is it this year or last year? I think this year. Last year. One of those times. Sounds so recent. And what she presented with had jaundice and all those things. And what we discovered, when the liver had nodules. And in that nodule, when we did histology, we actually found that she had hepatocellular carcinoma, but there also cirrhosis around the thing. And when we did back now, like it was, as I said, it's multidisciplinary, we discovered actually that the hepatitis, because we now did tests, the blood test, we looked for hepatitis, it was positive. The AFP was positive, because now they were already having hepatocellular carcinoma, it was increased. But the hepatitis was high. So that's how we knew there was a problem. Okay? That there was a problem.
Yes.
Yes. So I'm suspecting maybe even the 15-year-old, I don't know, it could be autoimmune disease, it could be any, but could have been, if we had done more tests and evaluated, maybe it could have even been hepatitis B. Let's see. I'm just saying, leading to that problem.
Mm-hmm.
Mm, mm. Okay.
Asante.
Yeah. Any other queries? So there's a lot to in the liver, and the fact that we don't teach all the diseases as it is now. We pick what is more important, like what we are having now. Okay, then you go and fill in the gaps. So I keep insisting your chemical pathology is so important when you're doing systemic pathology, because that's why you do the tests. Okay, and we relate both of them. You can't separate the two. Okay. Yeah, so you have to go back and read your pathology, your chemical pathology. Look at the gaps that you have and add on to that. So don't forget the assignment that I've said of looking at your chemical pathology, as I said, and then reviewing the liver function tests, like those parameters. Why are we doing them? What is the reason for doing the parameters? You see in results of liver function, okay? That you discuss. Good to know about those symptoms too. Your bullet number 3, a must know, a must know. So you have to go back to your notes and see. If you're saying, I've sent a patient for liver function test and I have high levels of total bilirubin and direct bilirubin, what picture does that show me? What does that mean? How does it show me where the disease process is? So that's why I say it's a must know. I think, Julius, you did that in your chemical pathology, isn't it?
Yes, we did liver function tests, even in clinical
Yes.
biochemistry.
At clinical?
Biochemistry.
There's nothing like clinical biochemical called clinical chemistry or chemical pathology.
We call
Because
it bio. Is
biochemistry
it?
will be, because that one will be normals. Now, here we're looking at the abnormal liver function. If I have high levels of bilirubin, what does that mean? You did that, right? And the diseases associated.
Yeah, we did about the tests in pathology 5.
Mm. So you're able to say, like, when I talk about an increased, say, gamma GT, what does it imply? If I have a patient who has a high levels of gamma GT, what does it mean? You did that.
We did the liver function tests. We looked at, I think, on the enzymes, the LPs, AST.
But gamma GT is an enzyme, yes, or alkaline
Yeah,
phosphatase. If I have high
yes,
levels of alkaline phosphatase, what does it mean? You did.
yes, we did that.
Okay. And the ratios of ALT to AST, when you're talking about liver hepatitis compared to other diseases, there's usually a ratio. You did all those. Okay, fine. So those are the things I'm telling you to go look at, because you have to divide liver function. You look at detoxification function, which is the bilirubin. You have to look at that. You look at the enzymes and you classify the different enzymes and what they will show. If it's high alk phos, you're looking at obstructive disease, for your alkaline phosphatase and a bit of gamma GT. If you're looking for toxicity like alcohol or drugs, you're looking at your gamma GT. You classify like that. Okay. If you're looking for coagulation factor, even though you don't do it there, for when you want to look at the synthetic function of the liver, you analyze the albumin. So we usually do total protein and then albumin, because total proteins, other proteins are not just done by the liver. There's that is done by, like, your lymphocytes. They're coming from marrow. So you have to minus that. You did all that and looked at like an electrophoresis for albumin and all. Okay. So albumin, you look at it. So if you say total protein, you look at the albumin levels also. And there's what they mean. You broke it down like that, right?
We didn't break it down the way you're explaining. I think that we just look at the general LFTs.
But you have to interpret.
So,
So what I'm discussing is interpretation.
so I
You
think we read more.
Hey, mmefanya juu sana. Nyinyi, that one will not help you. It's too superficial, my dear. That sounds very superficial, and it's a very important topic. That sounds quite superficial for liver, because liver function is deep. I'm just trying to see, because you have to break it down. You because usually, let me just give you a hint of the way you should read for that for the liver. Let me stop projecting this one. Because if you haven't done details, I've been unable to stop sharing. Okay, let me see. Oh, unfortunately, I've been unable to share the screen. I don't know why. Okay, my screen is refusing to share. Maybe I just mentioned that in the liver function, the things I would want you to go and look at. You look at how you investigate, like you look at detoxification function of the liver. Under that, you look at bilirubin. That's how we even report it. So you look at total bilirubin and the direct bilirubin. Direct bilirubin is the one that is being conjugated inside the liver. Okay? So if you have a report showing you total bilirubin and direct, if direct is high, it means there's a problem conjugation within the liver. If you had total bilirubin and direct bilirubin, which is low or normal, if I could put it that way, normal, then you know the problem is indirect bilirubin, which is the one which is not conjugated. So the problem will be prehepatic. It's coming before getting into the liver for conjugation. And the commonest thing is hemolysis, anemia with hemolysis, hemolytic anemia. Then you go and look at enzymes. So enzymes will reflect damage to the hepatocyte. Okay. So if you're looking at hepatocyte damage, we'll start with your transaminases. That is your AST and your ALT. So ALT is more specific to the liver. Okay. Because AST, you'll find it in red blood cells, you'll find it in the heart, you'll find it as a cardiac biomarker, etc. But ALT is specific to the liver. So you want to see the levels of ALT to see disease processes within the liver. Then there's a way you even evaluate AST versus ALT to see things like hepatitis infection, viral hepatitis infection, etc. So you go look at that also. Then there are enzymes which we test to look at cholestasis. The bile stasis and all that, if there's blockage, that bile is not moving. So the test that we'll do is when you look at enzymes, your alkaline phosphatase, your 5-nucleotidase enzyme, and your gamma GT. Okay, so those ones will reflect cholestasis. Okay, so if there's blockage, they will be very high. If you have conjugated bilirubin, yes, but it is not going to the circulation, we're going to the intestine, etc., and moving forward because there's blockage. Either because you have a gallstone blocking the tract, then there's no flow. You'll have high levels of alkaline phosphatase, your 5-nucleotidase, and gamma GT. Okay? And then gamma GT also, you can use it for toxicity, like alcohol, chemical. Then you look at synthetic function of the liver. Liver synthesizes albumin and coagulation factor. So you look at that also, the synthetic function. So when you're measuring albumin, because albumin has a long, what do you call it, half-life, shelf life, it stays for up to 21 days. So if albumin is low, it means it's a chronic disease that has been going on in the liver. But if it is, you want to see the short acute liver disorder, then you look at the coagulation factors, which are synthesized by the liver. Okay, so you look at your INR, your prothrombin time, which I had shown you earlier. So that's how you analyze liver function. Okay, so you look at each and you should be able to interpret what you're finding. Okay, yeah, so I felt there's that gap. So you go feel it like that. Any test that you do, even though it's renal and you're doing chemical pathology of kidney, that's how you analyze each. If I'm saying metabolic acidosis, what does it mean? Which diseases are associated with metabolic acidosis? If it's is it compensated? And you should be able to calculate that. If I'm given blood gas analysis, you're given results because you're in ICU or renal clinic, renal laboratory, or your renal wing of the hospital. Are you able to interpret that and know how much you should replace? So that's what chemical pathology is about. So you have to interlock it. Okay. Yeah. So you go check those gaps and fill them up. Okay. Yeah, that's the end for me today. And see people have dropped out, like 10 people have gone. So I think it's high time even me I left.